Well, hello, and welcome to Back to Basic in Denture Technology. This lecture is going to be presented by Dennis Urban, CDT. Now, it is my extreme pleasure to introduce to you tonight's guest lecturer. Dennis Urban, CDT, brings more than 45 years of expertise in the dental technology, encompassing laboratory management, education, product development, and digital innovation. A globally recognized lecturer since 1985, he has presented to dental professionals worldwide and authored numerous technical articles across leading publications in the US, Canada, and Europe. Dennis has held key leadership roles with the Long Island and New York Dental Laboratory Association, served as chair of the NBC in Dental Technology, and sits on the NADL Executive Board, and is honored as the 2024 CDT of the Year. It is my extreme pleasure to introduce Dennis Urban.
All right. Thank you, Nicole. Thanks so much. I appreciate it. And welcome, everybody. And tonight's lecture is going to be on Back to Basics with Full Denture Technology. And this course is, I know everybody's ready, is chomping at the bit with digital dentures and technology like that, but you really need to know the basics. And we have a lot of good basics and in-depth basic denture technology tonight that we're going to speak about. And I'm going to cover any aspects of anywhere from occlusal registrations to setups and everything in between, and also materials. So thank you for joining us tonight, and thanks Nicole and NDX for having me on this webinar here. So we're going to get started because we have a lot of information here tonight. So let's get started here. So this is me. I'm usually at my home here doing these webinars. This is me in my dining room. I took over the dining room. My wife got mad at me, but I'm set up with my computers and my microphone. And like Nicole said, it's over 45 years in the dental industry. And my wife reminded me a couple of weeks ago when I was doing a webinar, I said it was 45. She goes, Dennis, it's 50 years now that you're doing this. I said, thank you for making me feel old. So it's been a while, and it's been a good run. So and I've had the opportunity to travel the world, lecturing, training, learning, and seeing dental offices, dental practices, dental laboratories, and it's been really fulfilling. So I'm going to share some of my knowledge on the successes I've had with these techniques over the years in both the laboratory and in teaching. So let's get started. So tonight's learning objectives was going to be identify the difference between lingualized occlusion and physiological centric relation. And at the end of the course, you should be able to obtain the correct information to submit a full denture bite registration accompanied by the corresponding occlusal records, and identify anatomical landmark concerns and incorporate solutions into case planning. So the outline of the presentation tonight, we'll go through this: preliminary full denture impressions, custom tray final impressions, full denture bite registration, occlusal records, and getting the correct information. Anatomical landmark concerns, tooth selection, wax setup for try-in, lingualized occlusion, and material science. So we have a lot of stuff to cover here tonight. And I like to just start out at the beginning here. So with removable technology, looking back, look at the top right picture here with the George Washington dentures, and on the bottom here, these are old rubberized vulcanite dentures. I saw these when I first came into the industry once in a while, and when we had to do repairs on these, it was a mess. It really stunk. The material was horrible, but the fit was great. So we come a long way with this since that time here. So moving forward, the technology has changed so much with new advancements with materials, with denture-based acrylics, denture teeth, printed materials, digital dentures milled and printed, partial denture materials, implant dentures, and software for designing. So we have a lot at our fingertips now. Years ago when I used to go to a dental meeting or a dentist meeting or a lab meeting, I never saw that much about dentures. Didn't have not much exposure. Now I go to a meeting, all I see is dentures, digital dentures, denture technology, and there's a lot of opportunity with dentures in the market. So now we have highly aesthetic teeth and unsurpassed denture-based materials. Look at those aesthetics. These are all different high-end denture teeth here. Denture-based stain. Look how beautiful those dentures are. We want a denture that's not going to look like a denture. And the patient doesn't want to look like they're wearing a denture either. They want to look natural. And we're able to do that with today's technology. And now we can match the existing gingiva on a patient. Look at this beautiful denture. This is with PhysioDens denture teeth from Vita, and this is with denture-based staining, trying to match and mimic the patient's natural gingiva. And this is just applying that denture-based stain with a light cured material. And I talk more in depth about this in my Excellence in Denture Technology seminar, which will be coming up in a couple of weeks. Now we can mimic natural gingiva anatomy on wax try-ins, utilizing artistry and various shaded waxes. So this is how my denture try-ins went out of my laboratory. So I characterized it. I got a little crazy. I charged extra for it. I used to get a photo from the doctor from the patient's natural gingiva. I would mimic that in the try-in. And I figured, we have diagnostic wax-ups for crown and bridge. Why can't we have a nice characterized wax-up in a denture try-in? So of course I charged more for this, and it took a little extra time. Then I would take a photo of the try-in, and when the case was finished, I applied the same type of stain and staining on the final denture base. And there's another try-in I did, not as dramatic as the one before, but you can see the anatomy on here with stippling, eminences, and nice carvings. So now we can print and mill accurate aesthetic dentures with amazing fit, form, and function. We've come a long way. With printed technology, if you asked me maybe 5 or 6 years ago about printed technology, I wasn't a big fan. The materials weren't as good as they are now. It's evolving so quickly, but we still need to know the science and the basics behind what we're doing with dentures. So this particular denture here, I made this 6 years ago. This is my first digital denture, and I utilized the Diamond D material from Keystone. It's made in a puck, and I milled it, and I just bonded in Vita denture teeth into the denture base. It came out pretty nice. So I still think that the milled denture bases look a little bit better than the printed denture bases. So very nice denture. I'm excited about digital technology, but I'm also excited about the analog portion of it. Of course, the majority of dentures still done in this country is still analog. So as we can see here, back in 2021, the survey was done by the NADL. Only 8% of full dentures were digitally manufactured, and traditional manufacturing was about 92%. Then jumping from 2021 to 2024, full dentures jumped to 21%. Now, from what I hear, in 2026, we're up in the 30s, in the high 30s now, as far as digital versus analog. But if you look at the processing, as far as the aesthetics and the number of denture sales, most of them are still done analog. And highly aesthetic dentures, about 29% in the industry. And full dentures are about 60%. And denture acrylic is still being, the majority of denture processing is still being done by press pack or compression pack, and it's about 55%. So we're still in the analog world, but we're getting over to the digital world slowly. So where are we going with denture technology? More people need dentures now than ever before. So the industry predicts tremendous growth now through 2050. Experienced denture technicians are the guides for dentist and patient success in denture prosthesis. This was a quote by Dr. Stephen Wagner, who's a prosthodontist, and he was crucial to bringing the Lucitone print to market from Dentsply with digital dentures. And I was at a meeting a few years back at the Seattle Study Group meeting in Phoenix, and Dr. Christian Coachman got up on stage. He said, "Professionals who understand dentures are the ones who understand smile design." And he's correct. I said, "Oh my God, somebody's finally really recognizing us denture technicians and people who really do a lot of dentures here." Because, yeah, we have an intraocclusal space to fill over 40 millimeters, and we have to make it look natural. We have to make it functional, and we have to make it comfortable for the patient. So there's a lot involved in making a functional and aesthetic denture. So U.S. dental laboratories are seeing a dramatic increase in full dentures and implant dentures and partial dentures, and this is a reflection on the overall industry. More income opportunities for dentists, dental laboratories, dental material manufacturers. So yeah, there's a lot of growth opportunity out there on the removable side of the market. So some of the problems we've seen with full dentures in the past is compromised stability, poor neuromuscular coordination, bad occlusion, low tolerance from mucosal tissue on the acrylic base for sore spots, and the patient's desire for more stability and comfort. So many patients just don't wear their dentures because they're not comfortable and they can't function with it. And the comfort level of the dentist has been compromised due to excessive chair time and also a lot of adjustments. And so this, I remember the last seminar I did at one of the universities in New York, and I said, "How many people, how many doctors here love doing dentures?" And maybe about three or four raised their hands. I said, "How come there aren't more?" They said, "It's too much chair time." I said, "If it's done correctly and the communication is there, you can, and you're using the right materials and the science behind what you're doing, you shouldn't have any problems like that." So. The goals for the final outcome, we want to create natural aesthetics and hence enhance facial appearance, compensate for that lost soft tissue, and enhance the function with the right occlusal scheme. We're going to touch on this a little bit later on different occlusal schemes. We want to create a denture with longevity, impact resistance, and bacteria resistance. So the materials that I've been using, for the last 15, 20 years have been high impact denture-based material with flexural strength. You can't have one without the other because then it'll be brittle. And it has resistance to bacteria and great bonding to denture teeth. And we want to, for the final outcome, we want the elimination or reduction of adjustments in the operatory on occlusion and on sore spots. So some of the common mistakes is poor treatment planning, distorted final impressions, inaccurate master models, and insufficient occlusal records, and the poor choice of materials. I don't want to mention, which group it was. I had a large DSO group contact me and saying one of the most difficult things the doctors are having is getting sufficient occlusal records in the operatory. And so I did some education for them, and they were missing a lot of the vital things that they were supposed to be doing in capturing all the information for a successful denture. So when we talk to patient expectations, I was at a Dawson study group meeting, and one of the doctors said the dentist should meet the mind of the patient before he or she meets the mouth. I said, what are they talking about? I wasn't too sure what they were speaking about here. And what they meant was on your preclinical interview with your patients, but especially with new denture patients, what are your specific concerns or limitations? How long have you been a dentalist? How many dentures have you had since your tooth loss? And how did you lose your teeth? And when was the last time for those existing denture wearers, when was the last time your dentures were relined? There's so many patients who come in and get their denture and they never show up in the dental office again. They should be seen on a regular basis because things get compromised, occlusion, fit, and it can affect the whole overall function of the patient and the dentures. And if the patient's really having a difficult time, especially with lower dentures, ask, have you ever considered implants? In this particular case, maybe we can put two implants on a lower and have an overdenture made. It'd be more comfortable and functional for the patient. And for that new full denture checklist, we look at the patient complaints, the history of edentalism, tissue support, stability, retention. And I put this in here because it's important as a dental technician. I used to look for this all the time. And when I had my laboratory, I was in a building with 8 other dental practices. So I had the opportunity every single day to go chairside and watch the good and bad of what was happening with removals. So, and one of the things I saw that, a lot of times there just wasn't enough room for the tongue, on a lower denture. We didn't have that concavity and the dentures weren't finished correctly. So with the concavity, and you want that tongue to almost act as a retentive element. So we look at the ridge analysis in the tongue room on these types of patients. This patient on the right has a large tongue. Most likely, if the denture is not contoured correctly, that patient is going to trip that lower denture out of the mouth, and it's not going to fit correctly. So to continue the full denture checklist, we have to look at the border extensions, centric relation, VDO. Phonetics is a major part of it. We're going to talk about that in a little while. And aesthetics, occlusion, and of course, what the opposing dentition is. So, I know a lot of people had inquired before this course about whether I was going to be speaking about digital technology. I'm going to touch on it, but there is another lecture I do. It's called Getting the Edge on Removables, and we do analog versus digital. But what I wanted to do today is just touch on a few things with digital and analog. We still need to utilize the same fundamental prosthodontic processes to make a digital denture as we always have. The clinician still needs to communicate and provide the technician with the necessary information for a functional case. Digital denture technology is still evolving and improving at a rapid pace, but the basic knowledge, like we're talking about tonight, the basic knowledge of prosthodontic principles, including providing accurate impressions, is even more important in a digital world because of many details can now be seen on a large screen, which we couldn't detect otherwise previously. Dentists still need to understand the importance of capturing accurate maxillomandibular records vertical dimension, and centric relation. And technicians still need to continue to analyze ridge relationships and select appropriate anterior and posterior teeth for the desired occlusal scheme. So this is when we come into communication here, the communication between the dental laboratory and the dentist. It's really essential, especially with implant cases, to have that correct communication for the proper planning of cases. So collaboration is working with others to do a task and achieve shared goals. And this is what we need to do in our industry. So the ability of the certified dental technician and dentist to work together, plan together, and succeed together is paramount. Then the concept of collaboration will be fully evident. And it's only going to benefit the patient, the dentist, and the dental laboratory. So establishing a dentist-lab relationship, get to know your lab. If you're a dentist, get to know your lab, take a laboratory tour, ask what dental technologies the lab is utilizing, make sure the laboratory is FDA compliant, find out what communication tools are available, know the expertise levels of dental technicians. So, just recently I had left a large laboratory group, and one of the things we used to get requests for was for different technicians, especially in our ceramic department. And we had different levels of dental technicians that handled different kinds of cases. So, the expertise level of the dental technicians that you're dealing with, and raise your comfort level on case planning with the designated lab manager or a CDT. So, talk about the dentist and the laboratory. So, case planning and collaboration is essential with both sides. Patient expectations. Yes, patient has expectations, but we have to come up with realistic solutions. Sometimes we cannot do really what the patient requests. We have to look at different things that the patient might have a difficult occlusal scheme, maybe not enough room for like an all on X case, something like that. We have to look for realistic solutions. Information transfer, patient history, past problems, solutions, material choice, and cost. We have to be upfront with that. So we have all these communication tools at our fingertips, and sometimes we just can't plan a case correctly. I'm shocked at this. And as I go around the country talking to laboratories and dental offices, a lot of times they say that the communication is just not there. So we really need to, capitalize on communication for case success. Addressing the successful outcome of a case, the dentist, the laboratory, the collaboration between both, and patient expectations and outcomes is important. So communication from the dentist, we depend on your clinical knowledge, your training, the appropriate treatment planning, and the detailed information on the RX is really essential. And I love to get a digital photography with for each case so I can see what the patient, facial features equals tooth shape. So I need to know the facial features. Maybe tell me about what there's a problem, maybe with occlusion. I've gone so far to get little videos of how the patient goes into this lateral excursion and see what kind of bite the patient has, so I can decide on whether to give the patient physiological centric occlusion, lingualized occlusion, or just regular centric occlusion on these types of cases. And the communication from the certified dental technician, you depend on our expertise on materials and procedures, feedback on impressions, bites, shades, etc., collaboration on case planning, and the proper workflow. So we are here for you to help you get this case plan correct and to make it successful. So let's solve the case planning puzzle, and that can be solved with, like I mentioned before, information from you at the dental office and at the lab level. We need all the information we need to make a successful denture. So let's start in here with some of the basics here. Best practices on full dentures. So normally, traditional clinical protocol on removables used to have about 5 visits. You can cut out a visit if a functional impression is taken inside the occlusal rim base plate. On the second visit, you can cut it down to 4 visits. So first visit is a preliminary impression. Then the second visit, you can take a custom tray final impression. Third visit of bite registration. Then a tooth setup and waxing, and then the final insertion. So let's go through some of the protocols here on each one of these. So essentials for a successful case: we need the right materials, we need the right shade, and we have to need the right occlusion and materials. So preliminary impressions, got to utilize most of the time a stock tray and take an impression with quality alginate material. And we want to make sure all the anatomical landmarks are captured in the impression, because if we can capture as much as we can in accuracy with the preliminary impression, then we make our custom tray final impression. We're going to have a nice, accurate custom tray for great impression. So when you talk about custom trays, it's really important to fabricate them correctly. And when I fabricate my custom tray, I leave about 2 to 3 millimeters from the periphery to the edge of the tray, so the dentist can do some border molding. And that's really important to have, and I'll go through some of the border molding techniques. And that's important to get that border molding for a really intricate and successful impression. So let's talk about some of the custom tray materials on the market. So you want a custom tray material that's easy to use, it's reliable, has dimensional stability, uniform thickness and strength, even an easy adaptation to cast. And years ago, we had shellac-based plates we used to heat up with a torch and adapt those to the model. And when we put it in the patient's mouth, what happened? It got kind of warped. Then we would also make base plates out of acrylic. But now we have the light cure tray technology that really works well. And I like the Stern-Tech material. It's a great custom tray material, and I've used it for many years. And this is some of the techniques I've used. I prepare my dry models. I mark them as normal. I block out any undercuts with wax or putty. Then I apply a thin layer of separator, tinfoil substitute. There's a lot of different brands out there. I like the Diamond D or the Key Foil material. I take that custom tray material, I start adapting that to the model, and I put some separator on your fingertips, and I adapt that tray base plate to the custom tray material to the model. I'll trim away any excess material with on any of the border areas, about 2 to 3 millimeters from the periphery with a hot bar Parker blade. And then I'm going to trim it, and then I'm going to, after it's cured, I'm going to trim it, and then I'm going to trim the borders. So real simple. After that, and that's your custom tray. So it's a great material. This is some of the separator. There's a lot out there. This is some of my favorites. I don't get anything for talking about these. I've been successful with these two separators over the years. And then I like cure probably about 2 to 3 minutes in the light cured unit. This Pro Cure unit is one of my favorite. Triad, they don't really make this anymore, this unit here, but the one on the left, the Pro Cure unit, really works out well. It's only a couple $100 too, and it has good results. So this is a tray, one of the trays I fabricated 2 to 3 millimeters short of the border. And that's going to enable you, the dentist in the operatory, to border mold this and take a nice accurate impression. How about tissue stops? We still get tissue stops requests once in a while. I was getting those. But what happens sometimes with tissue stops, when you make your custom tray, you're getting that tray material inside the tissue stops. And many times when the dentist is taking the impression, they put a lot of pressure. And those areas where the tissue stops are compresses the tissue in the mouth. And then when you pour a model up, you got little indentations in your model, and you have to relieve that in the final denture. And sometimes that affects the fit. So am I a big fan of tissue stops? Not really. So I get once in a while, I get requests for it. Perforations, the same thing. A lot of times we get asked for perforations on the tray. You don't really need it now with the adhesive, especially with polyvinyl impressions. The adhesive they have now, what happens with perforation sometimes a lot of the material is running out of those holes in the tray and you're losing material. So, it's up to you, but I rather have a solid tray, and this way the material stays in the tray. So I mentioned earlier about the functional tray with a functional occlusal rim. So this is a typical, it's a base plate material you see here. I put an occlusal rim on it. And so the doctor's still going to border mold this and take a bi-registration and an occlusal registration at the same time, eliminating a visit, for the patient. So that bi-registration, using the functional impression with a therapeutically designed bi-rim, is one of the most reliable ways to transfer the oral situation to the articulator. And when in a laboratory, dental technician wants to feel like the patient's at the bench with him. And when you get us all this information and that we need, using the right articulating system and the information on the occlusal rim, it's really beneficial. So this is that final impression. Border molded it nicely, got all the anatomical landmarks, the hamular notches and the retromolar pads, the borders. This is going to be a good fitting denture, and the doctor took a bi-registration at the same time. So when we're border molding, first thing we're going to do is border mold. We're going to paint some the adhesive if you're using polyvinyl material, which I like the best, the VPS vinyl polysiloxane. Paint that border area with the adhesive. Apply the monophase material or heavy body material to the borders. put it in the patient's mouth, have them move their cheeks and capture all the musculature. And once that material sets up, take it out of the mouth, and then you're going to be painting more of the adhesive on the rest of the areas and coming into the mouth again with either light body material or medium body PVS. So, and this is showing the border molding of a custom tray. And this is showing, actually, this is actually showing the border molding with a reline material. You know, if you don't have that any tray material, a reline material works well also. So, especially the chair side reline materials, it's also a polyvinyl. It's probably a little more expensive though to use this than the monophase material. So let's take a look at this inaccurate impression here. You know, so we have lost detail from excess saliva, pressure areas with overextension of the tray. You can see those blue areas showing, light blue areas showing through. So you can see this impression. When I look at this impression now, I'm saying to myself, you know, after doing all these dentures all these years, I'm saying to myself, this is going to be a problem. It's going to be, you know, I see some compression even on the papilla here, so it's going to be a problem with sore spots. So, and also, you know, I'm not bashing polyether impressions or anything like that, but over the years, I've seen when compression on polyether impressions tend to compress the tissue a little bit more, and I tend to see more sore spots on full cases. You know, so in this particular case, I would probably make a new custom tray, pour the model, make a new custom tray, come a little bit shorter on the custom tray so the doctor can border mold it correctly. How about this impression? Huh? This poor patient, right? I probably was sitting sitting back in the operatory chair, and then all this material went down the patient's throat. You know, probably gagging, and you could see it wasn't even border molded correctly. You know, so it's like I want to see if I could pull up my my marking pen here so I can see. Do my laser point. Yeah, so this area here, I mean, you can see the custom tray here, so it's never border molded. So possibly the patient was sitting back in the chair. So when I got this, I said, I feel so bad for the patient. I actually called the doctor and I said, Doctor, can I make a new custom tray for you? No charge. I just wanted you to get it right this time and maybe have that patient sit up in an upright position and border mold it before we take the impression. So, and this is a great impression right here. We captured all the anatomical landmarks. It's beaded and boxed and ready to be poured. So, the reason why I stuck this in here today on wash impressions, because, you know, with digital technology now, and we'll talk about this in a few minutes, we'll get more into detail. With digital technology, with scanning fully edentulous arches, still having a hard time. I'm still having most doctors having difficulty capturing all the anatomical landmarks we need for a successful case. So that's when I tell everybody, is, you know, digital technology on dentures, many times it's not fully digital. So what we're doing is, if the patient has an existing denture, yeah, we can take a nice wash impression, scan that wash impression, scan the bite registration, and then send the STL file to the laboratory so they can start on the digital denture. So we're going to talk about some of the techniques that are successful with wash impressions, because I know a lot of practices are having trouble with preparing the wash impression and taking a wash impression. So before taking that wash impression, just ensure that denture is clean, dry, and free of any debris. Remove any excess moisture with a tissue or cloth. Also ensure that the patient's mouth is clean and free of debris also. So then have the patient rinse their mouth with water if possible before beginning the process. So once the prep work is out of the way, you'll need to choose the wash material. And I recommend a light body wash material, PVS material. It has a lower viscosity, makes it easier to flow in the nooks and crannies of the denture. And the chosen material should also have a reasonable working time, so you have enough time to place it slowly around the denture and putting it in the patient's mouth. And be sure to do any border molding, before you put it in the patient's mouth. So taking that wash impression, I went through this also with the border molding. Take that impression after you put it in the mouth and mix your wash material. Usually you have an auto mix material and just insert it in the patient's mouth. And there's your final wash impression. So you have a nice wash impression here. This particular case probably going to be a digital denture. We're remaking this case, and the patient it wasn't in bad shape, so we're able to use this as almost like a custom tray and take a bite registration at the same time. Some of the things you have to watch out for is make sure not to apply too much pressure. Once you see these pressure marks, the denture showing through the impression material, then I think you're going to have some sore spots and instability. So a lot of doctors prefer to remount the denture a little bit beforehand to allow for the room for the impression material. So, final outcome of the wash impression, you want it. It can be straight forward process, provided you follow the right techniques and protocol. including using correct material. So and utilizing the step-by-step guide I just mentioned, that's going to lead to better outcomes and patient satisfaction and better function. So now, what about intraoral scanning for full arch cases? Scanning is possible, but still not perfect, and additional steps must be taken, and case selection is crucial and critical. You can use an indelible pencil or marker to help with stitching issues. When scanning a particular arch where there are a few landmarks for reference, that indelible pencil helps, really does. In cases with tissue texture and landmarks, they're going to be easier to scan as well. You want to make sure to capture all those anatomical landmarks, and it's really important. So we're still having some difficulty. I think we're getting there. I think in the next few years we're going to have that technology really come forward and improve with fully edentulous cases and scanning. So I'm going to show a scan. One of the articles I love is from Professor LaRusso on edentulous scan strategy. And this is from 3Shape. And if you go on the website, all you have to do is punch in 3Shape and put edentulous scan strategy, and you get a beautiful PDF with a step-by-step procedure from Dr. LaRusso. So he had this design for optimal scan experience on edentulous patients with 3Shape trios. And he had a directional scanning strategy that he's been really successful with. And so as you can see here, on the upper, he starts at the hamular notch and he goes all the way around to the other side. And then the second step, he'll go in the palatal area like this. And then he'll start from the midline, go back to the hamular notch here, and does the same thing on the other side. And he's been really successful with that. And on the lower, he'll start from the retromolar pad on the lingual and go to the midline, come across and go onto the buccal side, and then come back to the midline again and go to the retromolar pad on the other side, and then to the midline. He's been so successful with this. He wrote an article, and it's speaking to a lot of people who use this strategy. It really works well. On the other hand, the Journal of Prosthodontic Research from February 2020, they did an in vivo feasibility study on computerized optical impression taking of 29 patients. Their conclusion, they said, within the limitations of the present study, the investigative scanners were not able to currently fully replace conventional impression for the fabrication of a complete denture. So I was surprised to hear that, but when I saw the pictures of the scan strategy, it sort of made sense. So I'm going to show you this, but if you want any information on this, this is from the Journal of Prosthodontic Dentistry. All you have to do online is punch in this title here, and Journal of Prosthodontic Research, and put in vivo feasibility study, and this will come up. And this is all the people who were involved in this study. So we'll take a look at this as a scan strategy here. So what did they do here? It was like a zigzag. They did zigzag across everything, and even over here. And I can see why, maybe I don't know what scanner they used, but I see they were having some trouble with this. They could how this could be troublesome. So, if you use the right technique and the right scanner, you're gonna get good results. So. And this is a great scanning guide too. This is from iTero, and this is on their website, and it's a scanning guide for brand new dentures and existing dentures. And I'll show you with a brand new denture here. What are they doing here? They're using the exact same strategy as Dr. LaRusso did on these types of scans. So if you go to their website, they have this PDF also. You can go and investigate it. But I just like to talk about this a little bit. It's we used to get a lot of scans in the lab, but I'd say 60 to 70% of the fully dental scans were not successful. I had to call up and possibly get a wash impression from them and a scan of the wash impression. So when you take your final impression pouring models, what I'm doing is it's just mentioning that a type 3 stone is recommended for full cases. It's easier when you're doing conventional processing and analog processing to break apart that denture without breaking the stone away from the denture without breaking the denture. So type 4 stone is recommended for partial frame models because of the wear and tear of the partial frame coming on and off the model. So the yellow model stone is really the standard for the full dentures. And compression strength on the die stone is a lot more. It's 13,000 PCIs, and expansion is very low, but has resistance to abrasion, as you can see here. So very low expansive, and that's what I use on partial cases of anything with do with a partial. It could be Valplast, acrylic partials. This way, those teeth I know are not going to break when I come on and off the model and try these on after it's finished, also to make sure it's passive. So how about the bite registration now? Let's talk about occlusal registration and occlusal records here. So, like I mentioned earlier, you want to make sure that patient is in an upright position. Place that contoured occlusal rim and base plate in the mouth. Make sure there's no interference with the wax. You mark that midline, the high lip line, and cuspid lines into the wax. We need that at the laboratory level to really set up teeth successfully. Even with digital dentures, we need that information also. And if taking occlusal records for full upper and full lower dentures, place those V cuts in the wax in the posterior regions and place by registration material between the upper and lower. And just verify at that point the shade with the patient. And if possible, you can choose the mold of teeth and anterior arrangement. So let's talk about base plate and occlusal rims, techniques and materials here. And then we'll get into denture setups, occlusion, and finishing the denture. So base plates for occlusal rims and denture setups. Same technique I used before. I'm using the SternTech base plate material now. I'm going to apply a thin layer of separator. I'm going to block out any major undercuts on the model. I'm going to adapt that by putting some material, some separator on my fingers. Adapt it really well because, you know, the result I want to get with the base plate is I want that patient to feel like how that finished denture is going to feel. I want to adapt it really well. And when you're trying it in with and taking an occlusal registration and also with the denture setup, you want that really to fit well. I go as far as to even put a post dam in the upper model so that the patient really has suction with that base plate. And then I'm going to trim the excess with Bart Parker blade and then cure it in a light curing unit and then trim it again. So what's the function? You know, for base plate function, it aids in the transfer of an accurate jaw relationship to the articulator. Base plates simulate finished denture bases. It's utilized for occlusal rims and denture setups. And there's your finished denture bases here. So when the occlusal rim function, we want to establish lip support. We want to establish the correct occlusal plane level and arch form to record maxillomandibular relationships. And it's for recording information for the proper setting of denture teeth. And we need that information, the midline, the cuspid lines, the high lip line, and the low lip lines when it's sent back to the laboratory. So that upper wax dimension is about 22 millimeters from the periphery to the incisal edge. Occlusal width is about 8 to 10 millimeters on the posterior and 3 to 5 millimeters on the anterior. So I'm a stickler for really making a contoured occlusal rim. I want to save the dentist's time in the operatory. I don't want to see that doctor start spending 15, 20 minutes trimming away wax. So there are techniques that really eliminate that excessive time in the operatory, and we have some tools I'm going to show you in a few minutes. And there's a lower by registration from periphery to the incisal edge. It's about 18 millimeters. Same thing with occlusal width, 8 to 10 millimeters, and 3 to 5 on the anterior. And that wax trim is going to cover about 2/3 of the retromolar pads. Reason being, of course, your second molar, that's where your second molar usually winds up, is 2/3 of the retromolar pad. So all this cool stuff here. So when I'm making my occlusal rim in the laboratory, I'm going to use an Alma gauge. I'm going to use an Alma gauge also when I'm setting my denture teeth. And on an average, when you're setting the anterior denture teeth, you're coming out about 8 to 10 millimeters from the papilla. And so I'm doing the same thing here on this occlusal rim. I put the pin into the papilla, and I see the wax is about 8 millimeters coming out from the papilla. And I know that this is going to help the doctor in the operatory with a nice contoured type of occlusal rim. So then we can utilize a rim former. That's going to help us contour the occlusal aspect of the occlusal rim. That's used pretty much in every dental office and every laboratory. And then a good friend of mine, Joseph Colbeck, he came up with this template here for making occlusal rims and for denture setups. And what's great about it, you put there's a little slot here. It goes on the anterior section. It gives you the exact measurement. It goes on the posterior section here on the other side. It gives you the exact measurement there. And what I love about this too is you can check the 18 to 22 millimeters here on this tool here. This is an excellent tool. I gave all these to every technician in the lab that had to process or make occlusal rims. And then you see where it says 18 to 22 millimeters? Your Bart Parker plate goes right through that slot and makes a mark in the wax. So you can have the exact measurement for 18 to 22 millimeters. Really cool stuff. So again, the necessary information we need: midline, canine line, smile line, and approved occlusal plane. Good information here. There's your perfectly contoured bite rims. How about this by registration? Okay, so this is an actual case I got in the laboratory. So I don't know what kind of wax the doctor used on this. It looks like beeswax or alu wax or whatever it is. And I couldn't get that lower counter model to fit into this wax, no matter how hard I tried. So I asked the doctor, I said, Doctor, I got this by registration. I'm having a hard time with it. And he told me the 5 words I hate to hear most in the laboratory. Dennis, do the best you can. So I said, Doctor, I can't do the best I can. Let me make an occlusal rim for you. It was an immediate denture, so got a new impression, made a new occlusal rim, and the case worked out fine. So. So taking the occlusal registration, look at this patient here. She's having a hard time. She's sitting back in the chair here. She's trying to get into a physiological rest position. She's in a like class 3 registration here. She's like can't get in a comfortable position. Finally got her in a comfortable position. She's still struggling. If she was sitting upright, we can get, maybe massage her temples a little bit and get her in the right physiological rest position for a nice, accurate occlusal record. This patient here, no. We don't want the patient in that position, even with taking an impression, because you get the impression I showed you before. So we want to raise that patient up in an upright position. So this is some old slides here. I show these just to give you the information that what we need at a laboratory level and you should be doing in the operatory. We need a midline, lip line, low lip line and the high lip line, and the cuspid lines. So you can maneuver this, you can cut away the wax and contour this correctly so we know exactly where to set these denture teeth. You can control the angle of the mouth with the thickness of the wax. Maybe you want that patient to show a little more bulkiness in their lips. Maybe they're too sunken in. Tell us about that. Build up that wax a little bit so we know when we're setting our denture teeth how far to come out or how much to build up that acrylic. Have the patient pronounce different sounds, the F sound, A, B, C, D, E, F, G, something like that. Have them speak so you know how that anterior section is really affecting the patient's phonetics. Right, here we go. So yeah, so we have the patient speak a little bit, so you can pretty much get an idea. And then you see here, the tip of the nose to the middle of the ear, that's your camper's plane. But look at the occlusal plane, it's sloping down. So what do we have to do here? We have to trim that posterior region of the wax to have an even occlusal plane. So the doctor's trimming the wax, puts it back in the mouth, and now we have a good occlusal plane, and we can take up by registration. So we have the camper's plane here, nice occlusal plane. That's going to give us the correct information. This way, we're not going to be setting up these teeth in a reverse spiral situation. And the doctor can add some extra wax if he wants to show more anterior teeth, the incisal edge, so I know exactly where to go here when I'm setting my denture teeth. And there's also another tool here. It's called a papillometer. And I actually like this when on a final impression, because this papillometer here, you see this little notch here? That's going to rest on the papilla, and it's going to tell me where the patient's incisal edge is going to wind up. So that's going to also help me with the contouring the occlusal rim correctly also. So you can see here on the patient is closed here. So it's about 17 millimeters is showing here. I would probably add a couple more millimeters so the patient shows a little more anterior teeth. So this is a great measurement. Just tell me if go 17 millimeters if you want, but you can go an extra 1 or 2 millimeters when you're setting your denture teeth. So there's different types of articulators out there. When I'm doing full mouth reconstruction, I want to use at least a semi-adjustable articulator. I don't want to use a straight hinge articulator because I want something that's going to mimic true jaw movement. I want 110 millimeters between both condyles, and I want something that's going to really mimic that lateral excursion of protrusiveness. It's this way I can check this when I'm setting my denture teeth. And a plus is also getting a Facebook transfer. I don't have time to get into Facebook transfers today, but that's in my Excellence in Denture Technology course. And there's some simple ways to take Facebook transfers that really give us at the lab level the information we need with that exact cranium axis relationship so we can produce a good setup. Different articulators, you can spend anywhere from $100 to $2,000 on an articulator. But the thing is, we have to use a good articulator, something that's going to be, mimic true jaw function. So we're mounting on an average value or semi-adjustable articulator. That occlusal plane is marked to the occlusal plane of the articulator and parallel to the workbench. And the center of the model is identical to that of the articulator. So that incisal point is aligned to the incisal intercage of the articulator. So what I usually do, I'll put a rubber band around the incisal pin here. There's usually a slot here. There's little slots on the posterior region. That's going to help me with my occlusal plane and setting my model on the articulator when I articulate it. Because if we articulate these correctly, it's going to make it a lot easier for setting denture teeth. So it's mounted on the articulator very nicely here. Got the occlusal plane. Beautiful articulation. This is showing the denture setup. I'm setting my denture teeth, I usually set up my upper anteriors, then my lower anteriors, upper posteriors, lower posteriors. But this is just showing the setup here. And before it's waxed up for a try-in, after everything's set up here, look at it working and balancing, we're going to wax these up for a try-in, and it's going to be a nice setup here. Here we go. So when it's on the articulator, I want to feel like I have the patient at the bench with me. So we got the pupil line is equal to the occlusal plane. I'm 2/3 of the height of the retromolar pads here. Here we go again. And then I mentioned earlier with the campus plane, the tip of the nose to the middle of the ear. So I'm picturing this with on the articulator, I'm picturing the patient. And if I have a picture of the patient at this point, it's going to really help me. I also want to just remember the Frankfurt horizontal plane, the campus plane, and the occlusal plane. All that equals a good occlusal relationship and a good aesthetic type of setup. Okay, so an average dimension, 18 to 20 millimeters on the lower, 20 to 22 millimeters on the upper. So now we're ready for our tooth wax setup and wax dry-in. And we're going to touch on a couple of things here. These are some actual dentures that I waxed up. So let's talk a little bit about, I'm not going to stress too much on denture teeth today, but I'm going to just mention something what we really need to look at with denture teeth, using the correct denture teeth. You know, we want something with lingual anatomy. See how this lingual anatomy here? These are some pictures of dentures that were made, and this lingual anatomy. I have a nice rugae in here, and so I go as far as to actually take a wax pattern from the patient's natural rugae and placing it into the palatal area when I wax up my denture. So this is going to help with the patient's phonetics, especially with new denture new denture wearers, because many times with if you don't have that lingualized that anatomy there, um, what happens is that patient's tongue just slides off the lingual and this patient lisps, and it takes a longer time for that patient to really speak correctly. So I like to incorporate these types of teeth. These are Vita teeth here. Culture has some great teeth. Ivoclar has great teeth also. So you can look at those different types of teeth here. But we want to have something that's going to have a functional cuspal inclination of about 20 to 33 degrees. 33 degrees. Yeah, if you're using it like a lingualized occlusion, maybe it's about 15 degrees. Because this is going to help with better tearing and chewing capabilities with for the patient. It's a wider occlusal plane on these denture teeth. It's even better. Yeah, I see some denture teeth on the market that have these really narrow occlusal plane, and it doesn't look like natural tooth morphology. This is going to help you get the right denture teeth. It's going to help that patient function and wear their dentures correctly and eat correctly also. Then we have to look at the smooth transition from the crown to the cervix of the tooth. What's going to be best for that facial feature of the patient? So the emergence profile. And we want to have the right shading too. And you really want a high-end tooth because what happens with a lot of these economy teeth, if you have to adjust occlusion, once you get past the first layer, you're in a really soft layer, and that patient's going to wear those denture teeth a lot quicker. So if you're looking for a high-end denture tooth, something that has like ceramic fillers, like Vita has ceramic fillers. Ivoclar has some great teeth, so does Kulzer. And they really last a long time, especially with implant overdentures and implant dentures. Teeth wear down a lot faster, and you want something that's going to have a really strong relationship, a strong type of material. And so I try to stress that all the time. So how do we select these anterior teeth? So we talked about facial profiles before. You know, facial form equals tooth form. Let's keep that in mind. So let's look at the occlusal plane here, the parts of the face. Pupil line equals occlusal plane. There's your high lip line, smile line, midline, and then you have your cuspid to cuspid lines. And a lot of times we'll measure cuspid to cuspid to look at the tooth chart to pick out the correct denture teeth. There we go. And usually, I'll mention some anatomical landmarks to look at in a little while here, but this is a great illustration of what we have to look at when we're thinking about setting denture teeth. So we have to determine the mold by the shape of the arch. And I like to mention this too. If you look at the upper arch, right? Think about the upper arch. I look at the upper arch when I'm looking at the model. All these years, the way I picked out denture teeth is the shape of the anterior, the centrals are usually the shape of the arch. So if you have square tapering arch, you're going to use a square tapering denture tooth. And if you have a study model, that's great too. If you have a pre-existing denture, and if you have the markings in your occlusal rim, you could measure from cuspid to cuspid line. And then you go to your tooth chart And the manufacturer's tooth chart usually gives you an indication of what kind of anterior tooth to pick out. So a lot of different things you can look at, to pick out anterior teeth. But the thing I used all these years was the shape of the arch, and it's really worked out well for me. So, and I have to mention to you, I don't have the slide in here tonight, but I have a slide. I figured out how many dentures I made from the time I owned my laboratory, from 1980 to 1995. I made 69,000 dentures. And it was amazing because I'm looking back and say, how did I make that many dentures? I was doing a special number per day and per week and per year, and worked out really well. So by now I'm probably up to 90,000. And that includes partials and also overdentures and implant dentures also. And the amazing thing is that not one remake or no adjustments. I'm only kidding. I'm only kidding. We definitely had adjustments. So, but it's amazing how many dentures I figured out I made all these years. So anyway, I spoke earlier about tooth form and facial form. Tooth form equal facial form, square tapering face, square tapering tooth, square face, square tooth. So same thing here. These are some old slides, but they're still pertinent today. And if you look at sagittal and frontal considerations, the tips of the canines are usually equal to the width of the nose, and the width of the centrals are usually equal to the width of this philtrum here. So let's talk about setting denture teeth here. We want something that's going to have a harmonious and aesthetic effect. We want to set up those anteriors with aesthetics and the proper phonetics. And those anteriors are positioned individually and parallel to the pupil line. And the lower incisal edges are parallel to the upper incisal edges. And I'll show you what I mean here by the diagram here. So, and you look at the anatomical landmarks I mentioned earlier, 2/3 the retromolar pad is where the final molar is going to be, the second molar. And we wanted to keep those teeth, the posterior teeth, right on the crest of the ridge when we set up denture teeth, because anything off of the ridge is going to cause an unstable denture. And then anatomical landmarks, the papilla, are probably going to come out about 6 to 8 millimeters from here. There's sometimes 8 to 10 millimeters. And you want to make sure the hamula notch you follow the ridge factor here and set these correctly. So anybody I'm teaching setups to, I make them mark the model, and then they can look at these anatomical landmarks. So let's look at a case scenario here where we didn't get any information from the doctor on midline, cuspid line, high lip line. So we're going to go with the average values here. So this is 40 millimeters intraocclusal space. I'm going to do 22 millimeters on the upper and 18 on the lower to the incisal edge. I'm putting some wax on my base plate here so the setup wax sticks on there. And if you look at the minimum ridge resorption here, that's when I'm going to come out about 8 to 10 millimeters from the papilla. But what's happened I see over the years as I teach setups, I see dental technicians or even sometimes doctors setting denture teeth right on the ridge. So this is a resorbed ridge here. So what's going to happen if we set these denture teeth on the ridge? The patient's lip is going to be sunken in. It's not going to be aesthetic. So we really want to follow those anatomical landmarks and come out from that papilla. So we're going to place our upper central on the base plate, 22 millimeters from the periphery. As you can see here, there's a ruler. Then I take my Alma gauge. I come out about 8 to 10 millimeters from the periphery here. So, and then from the papilla rather. So I have my first central in. I have an idea of how these teeth are going to be set. I place the centrals at the correct inclination. Then I place my laterals out. And at this point, I want to get my occlusal plate. And I'm going to just utilize this occlusal plate to verify the incisal edge. So what I want to do on this is a great clear occlusal plate that I use. You can see the reflection. I want the centrals and I want the cuspids touching the plate. I want 1 millimeter of the laterals, 1 millimeter off the plate. I'm going to check for symmetry of the arrangement here. If I want to make a bolder arrangement or softer arrangement, I can do that at this point. So there's a central and canine touching the occlusal plate. And then I'm ready to set my lowers. I'm just going to follow the guidelines of the upper teeth here, but I do want 1 millimeter of vertical and horizontal overjet here. And especially for new patients, I want a little freeway space. I don't want the patient tripping that denture out of the mouth. So, and especially on a lower, and so I go 1 millimeter overjet and horizontal overlap. So I'm looking from the side view here. I'm going to place my laterals and cuspids following the guidelines of the upper. I'm going to make sure there's no interference. And then this is the case we talked about earlier. This is that functional impression with an occlusal record here. So I want to follow the doctor's guidelines in here. So I'm going to do what I'm going to do. I have to make a new base plate for this. So I'm going to toss aside this occlusal record and the impression, and I'll make a new base plate. But I want to just make sure I capture what the doctor gave me here, the midline, the custom lines, and the height. So I make a little putty index here, and this is going to help me set my denture teeth. And then there's a putty index. I'm setting my anterior teeth right to that putty index, and this is probably about 26 millimeters from the periphery, rather. So the patient wanted to show a little more teeth on this particular case here. So for my centrals, my laterals, and my cuspid, like they're touching the exact area where the doctor contoured the occlusal rim, so I know this is good. I kept that occlusal rim just in case I was questioned about it, and then I have that putty matrix also. Then I'm going to set my lower denture teeth that follow the guidelines of the upper. Now I'm going to select my posterior teeth. I have to look at the occlusal scheme, the measurements, so I can follow the mold chart. I want a semi-anatomical tooth. I don't want to use a 0-degree tooth because with 0-degree teeth, that patient's going to chew like a cow. It's going to slide back and forth and not going to be able to chew their food. So I want some sort of anatomical relationship here with denture teeth. So this is different types of relationships here, and we'll talk about this in a few minutes here. So most of the time I'm going to give a centric relation on these types of setups here. And typically the smaller the ridge, the less degree of the tooth, less degree of cuspal inclination, and the larger the ridge, the greater degree of cuspal inclination. And that doesn't happen all the time. And sometimes there's exceptions of the rule for the rule here. So that axial inclination of the posteriors to the center of the cranium, that's your curve of Wilson, as you see on the lower. It's going toward lingually and going towards the cranium. And that's going to give you the natural anatomical setup of these posterior denture teeth. And then I'm going to line those occlusal surfaces correctly here. The only time I'm not using these, the curve of Wilson here, is when I'm setting lingualized occlusion. I'm still going to have my curve of Spee, that curve from the cuspid all the way to the retromolar pad. I still want to have that, but I don't want to have the curve of Wilson. And reason being is because I'm going to have the lingual contact of the uppers going into the central fossa of the lower. That's going to relieve any off-axis stress on that denture. And even with this is perfect for implant cases, overdenture cases, but it's also good for full upper and full lower cases also. I want one centric contact, that lingual cusp on the upper, uncomplicated mandibular central fossa. You see right here, and touch that lingual aspect of the upper teeth and going right into that central fossa of the lower. Beautiful. That's going to relieve any off-axis stress with the implant case or even full dentures here. So what about physiological centric relation? And there's a doctor in Germany, Dr. End. He has a great book out too on physiological centric relation, and he actually designed the anatomy for physiodentist denture teeth from Vita. So what of the lower jaw and the upper jaw is achieved by the patient themselves. So easily, without external manipulation, it can be reproduced again and again from the rest position and guided neuromuscularly. And want that patient in a relaxed position. So, and we want that patient in an upright posture also. So look at this physiological centric relation on these models here. It's really a tight relationship here, so there's a lot of contact points. And I'm going to explain that just a little bit in a few minutes here. But look at the target of arrangement here. So when all the contacts have simultaneously and harmonious contact between the lower and the upper jaw, this represents physiological centric relation. But you can see there's contact on all the anteriors, all the posteriors. And for new denture wearers, sometimes this is very difficult. And for older denture wearers, this is kind of difficult to get comfortable with. So I don't use this arrangement at all times. Sometimes I do use it. Most of the time I'll have that freeway space, but I just wanted to explain to you just a little bit about the physiological central relation here. So let's talk about setting those posterior teeth. Just checking our notes. Want to make sure the central fossa of the teeth on a lower curve of Wilson, and there's a curve of Spee from the anterior to the posterior. Little review here for you, just in case you forgot. So I'm going to set my denture teeth on a case that we started with. So it's telling me my internet is unstable here. Let me know if you have trouble. Let me know if I'm not coming across correctly here. So anyway, so first thing I want to do is set my upper bicuspid here. Then I'm going to put that on, measure it on an occlusal plate. I'm going to put my occlusal plate that have contact with the first two bicuspids on the upper, and then I'm going to interdigitate and start setting my lower teeth to fall into place with the uppers. And what I'll do, I have contact on the first two bicuspids, and when I get to the first molar, I want to have the mesial contact on the first molar and distally off the occlusal plate. And then that second molar, I'm going to have totally off the plate up until the mesial part of the second molar. Everything's all set up here. I got a nice setup here. I check for, make sure there's contacts all the way around. You can also use that OMP template I mentioned to you before, and that's going to help align the buccal ridges of the molars and the premolars. And there's your final setup here, waxed up setup here. So nice, easy setup here. This is the technique I've used all these years. And I remember when I was managing a large laboratory in North Carolina, and they asked me to talk to the technicians there and give them an easier way to set up denture teeth. And they suggested the template method. So I'm going to talk about that template method in a little while. But we want that harmonious transition to posteriors. We want a completed individual anterior setup for a nice natural. That's going to help me with my my AMA gauge. 40 millimeters intraocclusal space, 6 upper anteriors. I set those first, and then I check my arrangement on the occlusal plate, touching the central and the canine. And now I'm setting my lower anteriors, 18 millimeters. So I have my upper and lower anteriors set, and now I'm ready to use the template. So I attach this upper template. This is an RTEX articulator, and I attach the upper template. This is going to give me my Curver Speed and Curver Wilson. So I'm going to set all my lower teeth. Curve template on the RTEX articulator. I set all my posterior lower teeth to the template here. Everything's nice, looks great. Right on the ridge, I got my Curve Wilson, Curve Speed. Look how nice those contacts are on the template here. And all I have to do now is set my upper anterior, my upper posteriors. And when I first started doing this, I said, oh man, I hope this lines up correctly. Time after time, it was correct. So this was a lot easier for the students I had, and even the laboratory technicians to set up these denture teeth. I verify everything. There's my lower tooth setup here. Nice, beautiful setup here on a lower. These are with Willie Geller denture teeth, and they're really anatomical teeth. Then I set my posterior teeth against the lowers. There's the final wax up for trying. There's a wax, different color waxes. I just try to adapt these waxes. I want precise shaping. This is going to help me eliminate a lot of finishing when I go to process a denture. So, and the patients love it. I've been in the operatory when patients see these try-ins come in and they see the anatomy and the colors and the fit of the base plate, and they get excited about getting the new denture. So, and then we just finish the denture, exactly like it is and with this contour. And which one would you prefer, the one on the left or the one on the right? So when I sold my laboratory, I had one of my accounts, one of the doctors called me up. He goes, Dennis, I tried a new laboratory. This is what they sent me. I said, he goes, I'm so used to your work. And no second molar here. It's not carved. There's no one, so you wouldn't get what you didn't get. We didn't get what you gave us. So they said, would you be able to do our work for us? I said, I can. I just sold the laboratory. So, but anyway, which one would you prefer? I would definitely prefer the one on the right. So there's your final wax up. So we're talking about processing techniques. We're coming to the close of the seminar here. Press back is still number one. Injection is number two. Pour acrylic is about 15%. Pour acrylic is okay, but there's a lot of free monomer for those patients who can't tolerate that free monomer. And the microwave technology is a great technology, and not that many people are using it. You can cure a denture in 4 minutes, and all that free monomer is dispersed out of the denture, and it really works out well with the material. Microwave acrylic from Keystone works really well. GC America has also a microwave acrylic. So when you talk about denture bases, what are we looking for? A natural look, a low shrinkage factor, great gingival shades, great bond to the denture teeth, impact resistance with flexural strength, and good finishing and polishing properties. And that's going to give you that color and fit stability. These are some dentures I made with just different shades from Diamond D acrylic. I helped introduce this acrylic about 12 years ago on the market. I think it's now the number one acrylic on the market now, but really high impact strength, great fit, great aesthetics. I don't get anything for talking about this, but I just want it's my preference for a great acrylic. And we have to look at the considerations with different acrylics on the market. High impact strength, flexural strength, natural looking shades, and also, with traditional milled or printed, we want that great bond between the denture teeth and the base. And this is the final denture in the mouth. Beautiful denture, right? Looks good. Nice denture-based stain. And it's very rewarding when you're in the operatory working with a doctor and the doctor doesn't have any adjustments and the patient can walk out of the operatory very pleased. And there's the final denture with the denture teeth. And there's a lower dose. I wanted to show you this lower, this with the concavity here to make room for the tongue. So a lot of great features here. And with that, I'm going to end the seminar. Artistry through denture technology. A lot of great innovations coming out through denture technology. And you can also contact National Dentist Techs and